Extract 1. Questions 1 to 12. You hear a physiotherapist talking to a patient called Martin Gregory. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Mr. Martin, what brings you here today?
Oh well, I had a reverse total shoulder arthroplasty surgery on my right shoulder 6 weeks ago, and I have a sling for the past 4 weeks. I've just been doing what the home health people tell me. I just can't lift anything. I have no shoulder hyperextension, and I just need to rehabilitate from that surgery.
So, you said that you can't lift things right now. How about what things does your shoulder keep you from doing that you'd like to do?
Well, pretty much anything is difficult. I can't hold anything that's heavier than a coffee cup, and I can't support my own body weight. I can't drive, and I can't really do many outdoor things like go fishing with my grandson and stuff. I also like to play catch with him. But I'm right-handed, and my shoulder hasn't allowed me to do that since I had my surgery. To be honest, I was having a tough time doing that beforehand.
Are there any other issues you face due to your shoulder, such as opening doors, or while navigating through your house?
Well, as long as I can do with my left shoulder, that's fine. But while doing anything, I just have kept my shoulder right here in the sling for most of the time. So I can't really do anything with that like putting on a shirt, and things are hard when you have to brush your teeth left-handed. It's kind of weird, as you don't do it often.
Yeah, I understand, Mr. Martin. That's hard. Well, I know you've had the surgery. Have you had anything else in your past, like a medical history?
15 years ago I had a rotator cuff repair. I have played a lot of tennis in high school and in college, and I think doing all of that really put a lot of stress on my shoulder. So I had surgery on that, and then the past year, I have had increased pain, weakness and loss of range of motion in the shoulder here.
Now, I want to know more about your past. Do you drink?
I have a beer every once in a while.
Okay. How many times a week do you drink?
I just have a couple on Saturdays.
Okay. Do you smoke cigarettes?
I don't. I used to, but not anymore.
Okay. I'd also like to go through some other details, just to make sure everything else is fine. Have you had any history, or currently any problems with your heart?
I do have hypertension, but I take medication and that seems to take care of it.
What medications are you taking right now?
I'm taking 2 medications with some goofy names, NSAIDs and Tenormin.
Okay, those are anti-inflammatory drugs. How often you take them?
Well, I'm supposed to take NSAIDs, 1 a day for pain, and Tenormin, I think twice a day.
Do you live with your family?
Yes, with my wife Gretchen.
What is your occupation?
I was a school teacher for 28 years. So now, I mostly do stuff for leisure.
Okay, how much did you exercise before the surgery?
You know, I tried to get out, and we have a little dachshund, so I would get out and walk him every morning. I take him down to the high school, that's down from the house, and we do about a half mile on the track every day. It helps to kind of keep me limber.
Yeah, that's pretty good exercise. Now that you are moving a little bit, what do you think the pain is at right now, on a scale from 0 being no pain, 10 being the worst possible pain imaginable?
It kind of fluctuates. But, I would say most of the time, it's right around 4.
Okay, and does it ever get worse?
In the mornings, it's a little stiff, and that's probably the most painful. Sometimes, if I roll over in my sleep, and that doesn't feel very good.
Extract 2, questions 13 to 24. You hear a physiotherapist talking to a patient. Eric Robertson. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
I know that you've been seeing my colleague, Mel, and she has left me some notes, but because it's your first time with me, Mr. Robertson, would you begin by telling me a little about your shoulder and the treatment that you've received so far? Let's start from the beginning, shall we? How did it happen?
Yes, well, I've had this problem now for 7 to 8 months because of an incident with an ice pick. I'm an ice packer, you see, so I'm constantly having to make this sort of motion to dislodge some ice. One day while I was working, I found that my shoulder just packed up all of a sudden. The pain was so intense, like nothing I ever felt before. And when I went to my GP the next day, he booked me in with Mel. And now you.
Was it the first time anything like this had happened?
Yes, it is.
And how long have you been at your job?
For 3 years.
And what were you doing before that?
I was working in a warehouse. I've always had similar jobs in a warehouse, picking and packing, that sort of thing, since I left school at 16.
And you're...
25 now.
Okay. What about your medical history? Any related injuries before?
No, nothing. I mean, I've been diabetic since I was little. The diabetes that means that I have to have insulin injected into me every day in my tummy. But I don't know if that will affect my shoulder. Other than that, nothing else.
Okay, Mr. Robertson. So, today I'm going to teach you 2 shoulder exercises that you can do at home that are really simple, okay?
Can I borrow a pen? I'd like to write it down.
Yes, of course. First of all, I'd like you to relax your shoulders. You would need to lean over slightly, allowing your right arm to hang down. Then I'd like you to swing your arm in a small circle, about a foot in diameter. Perform 10 revolutions in each direction once a day. As your shoulder pain subsides gradually, increase the diameter of your swing, but never force it. Increase the stretch by holding a light weight, only about 1 or 2 kilograms, in your arm, okay?
Okay, and how often should I do that?
Only once a day. Have you got that?
Yes, thank you. You said that there was another exercise?
Yes. It's called the cross-body reach.
Oh, Mel showed me that one. That's the one where I would use my left arm to lift my right arm at the elbow and bring it across my body. She said to exert a little pressure to stretch the shoulder and to hold the position for 15 to 20 seconds.
That's it. You'd aim to do that one 10 to 20 times a day.
All at the same time, or should I space it out?
I would space it out.
Okay, thank you.
Is there anything else you'd like to go over?
No, I think we've covered everything. Are you allowed to give me medication, or is that something that I would need to see my GP for?
Medication for your shoulder pain, you mean?
Yes, please. I was on cocodamol before, but that was changed because it wasn't working fast enough. Right now I'm on codidromol because I'm not allowed to take aspirin, and that seems to be working just fine for the pain.
Let me have a look at your file. Oh, yes. Your doctor has authorized this, so yes, it looks like I can prescribe some pain medication for you. Let me have a look at this a little more closely.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. Now read the question.
Now, I just have to go through some possible side effects of the gastroscopy, if that's okay with you.
Yes, fine.
First of all, I can assure you that in most cases the procedure is problem-free, but I have to point out to you some side effects so that you are aware of them before you sign the consent form. Is that okay?
Yes, fine.
Right. Well, some people can have a mild sore throat for a day or two after the procedure. And if you have been given something to make you drowsy, you may feel a bit tired afterwards as well. And some people can get a chest infection or pneumonia. But remember, this does not mean that you will necessarily get these as well.
Okay, I hope not.
And on the odd occasion, the endoscope can cause some bleeding or infection in the gut, and can also puncture the gullet or stomach, but this happens very rarely.
I see.
Is there anything that you would like to ask me, or go over again, or are you okay with all this?
Question 26. Now read the question.
Let's see now. Mrs. T. Hawthorne, date of birth 4th February 1963, hospital number 1834572Z. She was prescribed tramadol today, 15th October 2009, given intramuscularly 50 milligrams, started on 13th of October at 11:30. All okay. Maximum frequency every 4 hours, maximum dose 600 milligrams. Okay. To be administered as required, intramuscularly and given by Senior Nurse Bond.
Question 27. Now read the question.
So, that's all done. Was there anything you wanted to ask me?
Yeah, I've still got this big gap on the other side. I remember you said we might do an implant there too, but that it'd mean a slightly different procedure. If I remember correctly, you said that you couldn't put one there because of the bone, but that you could connect it to the tooth next door. Is that right?
Well, partly. What we discussed was what we'd do if you lost the next tooth along. So we'd have to extract that one.
Right.
Then you'd probably need a bone graft there so that we could attach 2 teeth to a new implant. The gap you're talking about is where you've lost a big molar.
Right.
We couldn't fill that gap completely using this technique because that'd put too much pressure on the implant.
I see. Well, you said the price would be much higher than the one I've just had done. I guess that's why.
Uh-huh.
Question 28. Now read the question.
Challenges. I suppose there's positive, and we have to look for the positives of that. For me, a big challenge really in terms of nutrition is that everybody eats and drinks, so everybody has an opinion on what they are eating and drinking, and athletes are no different than the general population. You can hear messages or stories or information coming across, and sometimes that information might be suitable for Joe Public on the street, but in terms of an athlete that's training 2 or 3 times a day, that can often be a difficulty. And factor in a couple of other things like changes in body composition, trying to gain weight or trying to lose weight. Athletes sometimes struggle with those particular aspects of things, and quite often sometimes want to go for the quick fix. And sometimes my messages are quite often the longer fix type messages, and that can be a challenge. So I suppose for me as a practitioner, the challenge for me every day is to make that message real. It's to make it suitable to the person that I have in front of me, but also it has to be relevant in terms of the science behind it. So sometimes the science doesn't really change, so I have to change the message or the way I adapt the message for the individual.
Question 29. Now read the question.
OK, we need to do our debriefing. Any comments about the case, Jackie?
Well, we were late getting started due to a delay in getting the surgical consent to come in, but I've talked to the junior resident, and I think we just had a few crossed wires there, so it's sorted.
Yeah, we were busy in clinic this morning, but we were also delayed getting into this room because the case before us went over their time, which pushed us back. That's becoming a regular occurrence with that particular team. I'm going to ask our nurse manager to adjust their time slots based on the recent history of their cases.
We were also slow to get the portable films from radiology. There were several rooms requesting films, and radiology seemed short-staffed. That's unusual for them, but let's keep an eye on that, and if it happens again, raise it as a concern.
Question 30. Now read the question.
In bed 12, we have Liam Ogilvie. Liam's a 45-year-old male who was involved in a motorbike accident and was admitted with a frontal lobe contusion. He's broken his right arm and hand and has had surgery, including metal plates inserted into his arm.
Right.
He's also got deep grazes on his left knee and ankle and stitches on his right leg and shoulder. All dressings have been changed this morning at 9, and he's on self-administered morphine drip as well as an antibiotic drip. He's had injections to prevent blood clotting, and his pain's quite manageable with the medication he's on. The doctor's requested some observation and testing regarding memory loss, so that's priority this morning. His right arm's in a cast, and he'll need regular monitoring and a physiotherapy sessions booked later in the afternoon. Somebody's coming to collect him at 4. I've just checked his vital signs and he's stable with blood pressure at 135/95. It's a bit up, so you'll need to watch that.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, You'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1. Questions 31 to 36. You hear a doctor briefing his staff about the pathology report. You now have 90 seconds to read questions 31 to 36.
Hello, Doctor. Will you please explain to me about the type of information included in a pathology report?
Well, often a pathology report of surgical specimens is complex and very long. These are divided into many subheadings. The general information includes the name of the patient, the medical report number, the date of the biopsy or surgery, and the unique number of the specimen that is assigned in the lab. The next set of information often contains patient information provided by the doctor who resected the tissue sample. This information includes the special requests made to the pathologist and the medical history. For instance, if a lymph node sample is being resected from a patient with cancer in another organ, the doctor will indicate the type of the original cancer. This is useful in guiding the pathologist's selection of special tests that may be required to assess if any cancer in that lymph node is a metastasis from the original cancer, or else a new cancer that started in the lymph node. Gross description is the next part of the information. Here, the term gross means the details seen without using a microscope, by simply looking at it and feeling the tissue sample and measuring. In the case of a small biopsy, the gross description would be a few sentences listing its color, size, and consistency. Gross description would also include the number of tissue-containing cassettes submitted for biopsy. However, in the case of a larger biopsy or tissue specimen, for instance a mastectomy for breast cancer, this will have lengthy gross descriptions, including the size of the entire piece of tissue, size of the cancer tumor, how close the cancer tumor is to the nearest surgical margin of the specimen, how many lymph nodes were detected in the underarm area, and the particulars of the non-cancer tissues. A note of where tissue was taken from is also included. The gross description is very short for cryptology specimens. That usually notes the number of smears or slides made by the doctor. If the specimen is a body fluid, its volume and color are indicated. Microscopic description will include details such as the appearance of cancer cells, how these cells are arranged together, and the extent of invasion to the nearby tissue in the specimen. Results of any other investigations made, such as flow cytometry, histochemical, etc., may be indicated in the microscopic description or in an exclusive section. Diagnosis is the most significant part of the pathology report. Although this is the bottom line of the pathology, this section can be mentioned at the top or bottom of the report. The doctor relies on this final diagnosis information to decide on the best treatment methodologies. In case the diagnosis is made for a cancer tumour, this section will indicate the exact type of cancer and will include the grade of cancer. Once the final diagnosis is complete, the pathologist may want to include any additional notes for the doctors taking care of the patient. Often, this comment section is used to recommend further diagnosis or to clarify a concern.
Now look at Extract 2. Extract 2, questions 37 to 42. You hear an interview with a neurosurgeon called Dr. Ian Marsh, who specializes in the treatment of concussion in sport. You now have 90 seconds to read questions 37 to 42.
My guest today is Dr. Ian Marsh, a specialist in the treatment of concussion in sport, and a co-author on a new set of guidelines. So, Dr. Marsh, what's the aim of these new guidelines?
Well, the aim was really to provide a resource, not for the top-level professional sports people, but for parents, teachers and coaches of young people playing sport. The guidelines basically offer some expert information from a GP, an emergency physician, and myself as a neurosurgeon about what the condition is, also how to identify the symptoms and how to manage it. If any of your listeners have ever had a concussion doing sports, you'll know how frightening it can be. It's confusing and painful and difficult sometimes for teachers, parents or whoever to work out if someone with concussion is okay. I mean, we hope to remedy that.
And how do we know when someone is suffering from concussion?
Well, obviously if the person's actually knocked out, it's clear. But not all patients actually lose consciousness. Often, following a hard knock to the head, they become disorientated or experience headaches, nausea or vomiting. These are signs of concussion, and they may clear initially, but then return when the individual actually undertakes further physical activity. When they start to train, say. So it can actually take quite a while for things to really clear up. The essence of it is that people shouldn't start playing again until those warning signs have completely subsided.
Yes, and you say that waiting anything less than 14 days after all the symptoms have cleared would be too early to return.
Yeah, that's right. If they go back too early, they risk a second concussion, And as we know from professional athletes, they may have to give up their sport if they have too many concussions.
Right.
So it's better, particularly in a young person with a developing brain, to allow all of the symptoms to settle and only then return to play. Well, usually return to train first, then return to play after that. It used to be thought that receiving another concussion could lead to severe brain swelling, and that could be fatal, or at least involve a visit to the emergency room. I think the evidence is fairly slim for that. What we do know, though, is that the compounding effect of having one concussion followed by another seems to be more severe than just the one. So it's always better to let the brain recover fully before playing again.
Right, so who's at the highest risk of sports concussion?
Well, actually a concussion can happen whenever anyone receives a blow to the head. Usually it's a sort of twisting blow, not a straight-on blow. But obviously, people playing sports like rugby, where there's bodily contact, stand more chance of being at the receiving end of such a blow. But having said that, it's just as likely to affect kids kicking a ball around a park as it is to affect top professional players in big matches.
Do you think that youth sports need specialist concussion doctors on hand, like the professionals do?
There's always a risk, and we know that it happens from time to time. But I mean, most games, even the most dangerous ones, are without incident at all. I think people who are involved in running youth sports, whether they be referees, coaches or parents, can be made aware of how to manage concussion, the signs that they need to look out for, and maybe the warnings of something more serious so that they can take the appropriate actions. But I think always having a doctor on the sidelines where young people are playing is just an overreaction.
Right. In the USA, college football is big business. They're trialling helmet sensors and impact sensors. Do you think that's something we need everywhere?
Well, I don't think it'll come to that. I think there are two scenarios here. The first is one where a concussion's a one-off event following a significant blow to the head.
Right.
The second's quite different and involves chronic traumatic encephalopathy. This comes about particularly in American football, where players use their helmets and heads almost like weapons. That type of repeated impact seems to add up over the player's career. That's something we've heard being discussed, mostly in the USA. Naturally, there's interest generally in protecting players, particularly in the professional levels of sport, but I see that as a different matter to the management of concussion itself.
That is the end of Part C. You now have 2 minutes to check your answers.